a 23-year-old male from South Charleston. He started using drugs at age 16. He was snorting heroin, and then it went straight to IV heroin use. So between the ages of 16 to 21, he was using fairly heavily. He abused alcohol, but he ended up in jail in January 2020 for domestic violence, and then he went into long-term rehab in May. And sometime through these years, he has had 6 children by 3 baby mamas. And he smokes half-pack cigarettes a day, and he's not ready to quit at this time. No other tobacco, no vaping. And his comorbidities are mostly mental or psychological. He has ADHD, bipolar disorder, anxiety and depression, and a pretty severe case of acne. So there are his meds. He's been on atomoxetine 40 milligrams daily with good results. And he's on, I think that's oxycarbazepine. That might be, it's one of the anti-seizure meds. I forget what the brand name is, but that's for the bipolar disorder. He's been on vitamin D, and he takes mirtazapine 45 milligrams at night and hydroxyzine 25 milligrams twice a day as needed. He's done really well in rehab, and so he's excited to be almost getting treated. He is immune to Hep A. He's had 2 injections of Hep B. And you can see there he is immune with a good surface quantitation antibody. He weighs 226 pounds, 67 inches tall, BMI 35.4. And there you see his labs. His hemoglobin, hematocrit, platelets, all of his labs are good. His Hep B core antibody was positive. His APRI was 0.371, child Turco-Pugh 5, and MELD score was 6. And you can see his iron levels are okay. His vitamin D was right there at border, so that's why I put him on the vitamin D to get that up. Let's see, genotype 2B, and his first viral load is 10,800,000, and the second one was 15 million. And the fibrosis marker 0.02, which is good. And his ultrasound was normal in size and contour, slightly echogenic, suggesting some degree of steatosis, no masses or lesions. So this is, it seems like a pretty straightforward case. I guess I was wondering, I don't know how long he has had this, but follow-up abdominal ultrasounds, would that seems like that might be needed. I'm not sure about that. And then the medications, when I looked in the guidelines, he could take Clusa, Mavorite, Harvoni, Zepatier, but the recommendations, I guess, since he has a medical card, would be Epclusa or Mavorite. And that's it.
Awesome. Thank you so much, Tammy. Another great case. Before we jump into any of the recommendations, did any of the other participants have clarifying questions for Tammy about the case? Feel free to unmute or chat in. Any feedback? Dr. Rexford, I saw you chatted in as well. Thank you for that. Any recommendations from the hub members?
Actually, I just have one comment that I'm sure Tammy has already covered, but I would just be curious to know about his lipids and at least a fasting glucose, if not an A1C.
Yeah, I have that, the glucose anyway. I'm pretty sure I have the lipids. I can go back and check on that. Thanks, Jen.
It's kind of as an aside to the Hep C, but relates to the ultrasound too, and his BMI obviously puts him.
Right, right.
Dr. Pollywell, was there a question or comment as well?
No.
Thank you for that, Dr. Rexford.
Dr. Gilfus, did you have some comments as well?
Sure. You know, your genotype is going to limit your treatment choices to some degree, to basically just the pan-genotypic agents with Epclusa and Mavorite as your go-to. Fortunately, those are the ones that are available on Medicaid. So, so all is good. I'm fascinated with this guy's case to some degree because he sounds like a hard-living fella who is 23 going on 65. And I just want to emphasize a couple things that I think are interesting. You know, his steatosis already at age, whatever, 23. Remember, hepatitis C is a chronic inflammatory state. And this guy, I think, just has a genetic milieu, looking at his BMI, his steatosis. And then the other thing that caught my eye in the lab results is his white blood cell count. You know, leukocytosis is underappreciated marker of universal badness. How's that for a medical term? It's obviously we all key into it from the perspective of, you know, how does it give us, impart some knowledge about a biomarker for infection? And of course, it is helpful acutely from that perspective. But if you check it in somebody and it's chronically elevated, especially in somebody with an elevated BMI or risk factors for cardiovascular disease, remember leukocytosis, elevated WBC, is an independent risk factor, or at least it's a proxy for risk factors for heart disease and stroke. So throw that in terms of a fella who's got a impressive BMI already at 23, steatosis, and I think Jennifer hit the nail on the head. The Hep C is interesting, but there's his chronic need to improve his lifestyle is way more important. In terms of picking the drug, I'm going to have to request Rachel's help here. So in terms of giant categories of drug-drug interactions, we all know to remember the PPIs and the statins are important, which he's not on. The estrogen-containing oral contraceptives, which are impertinent in his case, anticonvulsants, and antiarrhythmics, especially amiodarone. And I know this guy's on Trileptal, probably not from seizures, but from mood stabilization. But I need Rachel's help because I can't remember off the top of my head if we have, it is an anticonvulsant, so I don't know if there are contraindications with either Mavorite or Epclusa.
Yeah, I was actually going to jump in here. The oxcarb or the trileptal, unfortunately, is an inducer of multiple enzymes through the CYP system and P-glycoprotein. So Really, any patient on oxcarb, there's really no available therapies for them, just because it's going to interact with all of the DAAs that we have. So doesn't really, at this point, it's kind of maybe going to have to be something where it's coordinated with whoever is prescribing that to maybe do an alternate therapy, because none of the agents, Epclusa or Mavyret included, would be able to be used for this patient. Going to put them at risk for failure for subtherapeutic levels of the drugs.
So do you know which agents would be okay?
Unfortunately, I'm kind of hard pressed to pick anything. Only, I mean, do you have any idea of things that he's tried before?
No, I sure don't. That I could explore that with him.
Yeah, just really important to remember the anti-epileptics. And Rachel, please correct me. The only anti-seizure medicine that's safe is Keppra, right? Or is it?
Yeah, Keppra is one of the ones that are safe. Keppra, lamotrigine, actually, the valproic acid, that's another one that's also safe.
Okay, that's good. Okay, well, I've got some homework.
That guy needs to lose some weight and commit to. I do view him as he's one of these 35-year-olds who can, in 10 years he could be having a stroke or something terrible. If just looking at a couple of his steatosis and the white blood cell count.
Okay.
Hey, Tammy, this is Kaylee. I just have one additional comment to make. I think everyone that's spoken so far has hit just everything perfectly. But I wanted to address your question specifically about his follow-up abdominal imaging.
Mm-hmm.
So, I mean, from a Hep C standpoint, he doesn't have any fibrosis, so he wouldn't necessarily have to have interval imaging for surveillance HCC screening. But again, because of his kind of, I guess, nasty milieu and his hepatic steatosis that was already identified on imaging, he's still going to be at risk for liver disease progression. And I'd say even independent of his Hep C being treated, he's somebody that I would even tend to kind of monitor long-term, at least until he gets his diet under control, weight under control, lipids, diabetes, all of the factors that, Jen and Dr. Gilfus have brought up still play an important role on even independent liver disease progression from Hep C. A lot of patients that kind of have that milieu, will always have some degree of steatosis, but it's the ones that have kind of the transaminitis that tend to progress that liver disease. And so there's not any specific guidance on how often you should be monitoring their liver status with ultrasounds or imaging or even liver panel. There's really nothing in the AASLD guidelines that says how often should you follow this, but since he's, has a history of pretty heavy alcohol use, hopefully he won't kind of go back there. But, what I would suggest is continuing to do an annual liver ultrasound and hepatic panel until his Hep C is treated, while he's working on the other factors, weight management, cholesterol, sugar control, blood pressure, avoiding alcohol, all that stuff. If his liver enzymes normalize after Hep C treatment and he's able to kind of get a rein on those other conditions, you may not necessarily need to do imaging every year, but just because he's so high risk for several conditions, that is something that I would kind of keep an eye on. Like I said, there's no specific guidance in terms of recommendations, but since he's at a higher risk of liver disease progression and he's only 23 and already has some steatosis, he is somebody that I would opt to monitor regardless.
Okay, thank you.
I love that advice, Kaylee. And maybe he's somebody, if you could ever get access to a FibroScan, the elastography, can potentially tell on him.
Okay, Thank you.
Thank you all so much. Tammy, were there any other questions before we go to Dr. Bailey's case about your case, or any comments?
No, I don't think so. I appreciate all the comments and all the assistance.
Regarding FibroScan, okay, what exactly we would be looking for that will really push us to get a repeat ultrasound done on this patient?
So the FibroScan is going to give you additional information on the stiffness of the liver and try to get you a sense of if there's non-Hep C related damage being done. So remember, your FibroSure that we do, the serum biomarkers of fibrosis, are pretty specific for the viral hepatitis, whereas the FibroScan can be useful for hepatic steatosis as well.
Okay.
Looking for stiffness. Stiffness is the answer.
Okay. I mean, I don't recall how it is being resulted. Is it a specific marker they mention in the FibroScan that we need to look for?
Yeah, the kilopascal. It's the kilopascal score. So remember the FibroScan is going to give you liver morphology, just like an ultrasound. And then the only additional thing is they take 10 points on the liver and send an ultrasound wave through it and give you a stiffness score in terms of kilopascals. And that correlates with scar tissue. And so it's a nice, the only additional thing you're going to get from a FibroScan is that kilopascal number, and that correlates to an F score on that you can look up. Now, honestly, it's every machine, like GE versus Siemens versus whatever, has different kilopascal ratings according, ratings equal certain F scores. That took us a while to figure out for our machine, but you can get that information from the radiologist.
And remember too, I mean, that's a good measure, but ultimately what it comes down to is this gentleman's going to have to reduce his lifestyle risks in order for his long-term health. So, I mean, it's good to get a elastography or a FibroScan to help assess that stiffness, but sometimes with an elevated BMI, it can also give an inaccurate assessment. It would be good to get that scan if it's accessible, and it's largely not accessible in West Virginia, but it would be good to get that just to kind of stratify further and use that as a teaching point for him that, hey, you're 23 and you've got, stage 2, stage 3 fibrosis, those kind of things. But ultimately what it's going to come down to is, even if he has some fibrosis that's noted on the elastography, it's really going to come down to just, minimizing his risk, and that degree of fibrosis can improve. But, that may be helpful in terms of him taking his health a little bit more seriously.
I think we can get that FibroScan.
Awesome. I hope you can. Yeah, it's a good tool. That's what we use here. It just kind of historically hasn't been readily available throughout the state. There's only a few places that I know of in the state that do it. So if you can get access to it, awesome. It's usually the assessment that I try to use rather than a fibro test, just because each of those tests is about $450. And so when I'm trying to choose, as from a cost management perspective, which one to do, I tend to go with the imaging modality, which is the FibroScan, over the fibro test if you don't have, if you can't get both. But I mean, an ultrasound and fibro test tends to be the next best that we go with.
Awesome. Thank you all so much. And thank you, Tammy, for that awesome case. Dr. Bailey, I noticed you were able to hop on. Are you okay to present your case now? I can pull it up for you.
Absolutely. I'm here. And I actually have a question that's related to fibrosis scans that you guys might be able to answer. So I'm going to, it fits well with the discussion that we just had. So I'm going to insert that here before my case. So I have another patient. I've been struggling with my chronic liver disease patients. Thanks to you guys, I've gotten really comfortable treating chronic liver disease, not just hepatitis C, but fatty liver disease. And we see so much of it. I think it's important to be comfortable with it. And recently, my not recently, but my patients with cirrhosis, you know, of course, it's appropriate to get EGD on those patients to monitor esophageal varices. And I do like to have a FibroSure on my NASH patients, or a fibrosis scan on my NASH patients to check their progression. But unfortunately here, most of the GI docs have them in their offices, or they're in the GI suites at the hospital, but they won't let me order them. The test has to be ordered by the GI doc. And so what's been happening to me is I've sent these patients just for endoscopy and for a fibrosis scan, and thinking that the patient would be transferred back to me for care. And what has happened almost 100% of the time is that the GI doc has then just kept that patient and took over care of that condition, which I don't think is necessary, and I'm mad at them for stealing my patients. But so recently that happened to me with one of my patients who has NASH, and she has her fibrosis score by FibroSure had been F3. She'd recently gotten a bariatric surgery, had lost about 100 pounds. Her liver enzymes have all improved. Her platelets have improved. She's Child-Pugh score A. Her MELD is an 8. You know, she does have cirrhosis, but she's compensated cirrhosis, and she's had cirrhosis for years. So when this GI got the fibrosis scan, it showed that she had very little elasticity left, was very high kPa, and so the GI doc referred her to a transplant center just based on her low elastography, or her low elasticity. That's the first time I've seen that happen, and I was really surprised by that. And I don't expect them to put her on a transplant list just based on that when she has a good MELD score and a good Child-Pugh and her platelets are improving. I was just wondering if you all had any experience about people getting put on transplant lists just based on their elasticity alone.
Hey, Dr. Bailey, it's Kaylee. I think that's interesting. I mean, it's hard because, you know, Jean Colonel, she's our hepatology expert here, and I don't think she's on the call today. I was trying to look at the participants, so I don't have as much experience with you know, liver disease that's not related to the viral hepatitis, certainly not what she does, but I've had several discussions with her. I mean, and she, you know, they have a pretty high threshold for when they send patients for a liver transplant referral. I mean, even those with decompensated cirrhosis, they wait until the MELD is 15 before they even consider referring to a transplant center, because they try to maximize, you know, medical management first. Mm-hmm. So it's interesting that you say that was a referral just simply based on the elastography value without kind of considering the whole picture. So I'm not sure with that information that I necessarily agree with that referral, but I don't, you know, I don't.
Surprised by that too.
Yeah, I'm very surprised by that, just because, you know, I mean, you can have a high kPa and still have stable cirrhosis, and a transplant center wouldn't necessarily just, you know, transplant a patient. I mean, they really wouldn't at all unless you know, unless there was some decompensation. So I'm just wondering if maybe they referred them for that just to kind of get the NICs, or just have at least that referral, or if the patient might have requested a referral to transplant, but I don't know how that would have happened. Yeah, I don't know how that would have been considered.
Okay.
I'm sorry. I wish.
No
no worries.
I mean, you have answered my question perfectly, actually, because that was just my question was, is that surprising to you guys?
Yeah, well? it was. I mean, that is surprising. I haven't heard that or seen of that. Yeah, usually they base a referral, I mean, on a number of factors, but one primary one is the MELD specifically, since that's more of a prognosis as far as, you know, in terms of kind of how long they're going to be around. I think it's like right. If a MELD's, you know, greater than 15, sometimes they have different thresholds, 18, 15, but sometimes 20, but I mean, it's, you know, poor prognosis within a few months if it's not addressed quickly. So yeah, I'm surprised at that.
Okay. All right, well, I'm going to jump into this presentation. So this is actually the second time that we've presented this patient. The first time we kind of had to get some more information. We have some more information now, though not as much as we would like to, because we're struggling with compliance with this fellow. He makes about 50% of his appointments, and sometimes we're able to get a hold of him on the phone, but it takes a lot of effort on the staff end. So mostly the reason that I wanted to present him today is because I am confused by his hepatitis B serologies. These are confusing. These unfortunately are from March, and we haven't been able to repeat those because we've talked to him on the phone a few times, but haven't been able to actually get him through the door to get labs done. He was following with our Suboxone program in-house, and so that's how we were able to kind of keep a hold of him for a while, because he would come in for those monthly Suboxone appointments. We were able to get labs and things. Now he's moved to a Suboxone clinic in Beckley, and so we're trying to reach that Suboxone doctor to see if they can maybe try to help us nail this guy down. We've had success with that in the past. So basically, this is a guy that has chronic hepatitis C, and I'm just trying to figure out if he has chronic hepatitis B or not. So let's kind of go through his whole history, and then we'll come back to those serologies. So you can see before you his comorbidities. This is just kind of everything that we have on his problem list, which probably needs to be cleaned up a little bit. Despite that list, he's a relatively healthy guy. Mostly his issues are related to his opioid dependence and his smoking. Go ahead and keep scrolling down, please. Not very many medications. He's on, well, he does have several medications. He's on torvastatin, the Suboxone, of course. There's a couple antibiotics on there. He's actually taken clindamycin long-term because he has a history of chronic osteomyelitis that was related to some instrumentation and some hardware that's in his leg after he got ran over by a truck. He is on gabapentin, metoprolol, lisinopril, vitamin D he's taking already. He has gotten his hepatitis A and his hepatitis B vaccines. He's slightly overweight, but not too bad. His labs are really looking pretty okay. His platelets are fine. Bilirubin and everything is fine. His iron levels have been fine. He's got a high viral load at 19 million. HIV with immune. He's genotype 1A. I believe his fibrosis score was F2, maybe. I have to get in his actual chart to see that. Let me do that for you real quick. How do I get it on full screen? There we go. So his fibrosis score. F1. Okay, so if you want to keep scrolling there, let's see, we have presented him in the past back in March, and then we got additional labs afterwards. So I think that's probably all on the presentation sheet. Yep, do you care to scroll back to the top so we can go back through his Hep B serologies? So this guy was non-reactive to hepatitis B surface antibody in March. Now we have started, I think, Jenna, do you mind checking for me to see if he's gotten the Hep B vaccine? I don't think we did because he was core antibody positive. So surface negative, core antibody positive. His core antibody IgM was negative. His hepatitis B E antibody was positive. His E antigen was negative, and I don't know that we have it here, but his surface antigen was positive, and his but his PCR was negative. So, you know, looking at the little chart, the one that we all hate from med school, it doesn't make any sense. Surface antigen positive, E antigen negative. I'm just confused. So if someone can help, that would be great.
Thank you so much, Dr. Bailey. And I might leave this case up here for everyone to still take a look at it, but any feedback or comments from anyone? I think Jenna also chatted in saying he has not had Hep B vaccine, pardon me.
Okay, gotcha. So I think we talked about that and decided not to, since his core antibody was positive. We didn't think it would be of any benefit to him. I hope we were right about that.
Mitra, should I go?
Absolutely. Thank you, Dr. Gilfus.
No worries. So I think you need another set of serologic markers on him to really be sure what's going on, Joanna. The most common explanation of what you're seeing right there is this is a person who's slowly clearing hepatitis B. So as I look at those serologies, there's undoubtedly he had natural infection that's supported by both the presence of core and epidemiologic risk factors. I guess he's probably got a history of IVDU and the presence of E antibody. So he undoubtedly has had exposure, natural exposure, and I would not vaccinate him. You remember, if you're deciding whether or not to vaccinate somebody with isolated core, one of the questions is this a false positive? Is this a person who's previously infected and then other serologic markers have declined over time, or are they immunocompromised? And this guy obviously is not that situation. He has epidemiologic risk factors and definite serologic evidence of prior exposure. I'll remember the surface antigen can take 6 months or so, even after you turn anti-E. So once you turn hepatitis E antibody positive and E antigen negative, you can maybe have another 6 months until it coasts down to undetectable. That's one explanation, and a one that you can test with just repeating serologic studies, most importantly a repeat surface antigen, and seeing if it went away. That being said, big picture, you know, I would not hesitate to treat this guy for his hepatitis C. I can't remember if we treated his hep C or not yet.
No, we have not yet.
No. Yeah, and Rachel, I was just an eyeball check on his meds. I didn't see anything that really looked worrisome. You know, Mavorite or Epclusa, if he's a Medicaid patient, would be fine from
the
our
only
perspective.
issue would be the atorvastatin that he's on, his Lipitor. That's technically contraindicated with the Mavorite, but so long as there's if he would use the Epclusa, the dose would just be some say would recommend 40, but really I think the package insert answer is that generic monitor for any sort of toxicity with the statin.
Yeah, and if I'm reading his viral load right, I think it's 1.9 million. So you could actually use Harvoni 8 weeks as well. So either Harvoni or Epclusa. Yeah, I would treat him, and then what I would do is while on treatment, monitor his viral load. He's not at zero risk of reactivation since his surface body has not become positive. I think that's here. Let me pull it back up. Surface antibody. Sorry. Antibody was non-reactive. Yeah. So he's certainly not demonstrated like good immunologic control, but he's also not active. Super active because his DNA is negative, and so he's somebody you could comfortably watch. He's non-cirrhotic. You know, you wouldn't want to be gambling if he was a cirrhotic patient, where if he reactivated Hep B, it would kill him. You'd want to be really cautious in that patient and maybe preemptively treat him for Hep B. But I think in this scenario, I'd feel comfortable and confident with monitoring. And heck, even the next time you check, his surface antigen may have gone away. You know, let me trace my comments. I don't think that's going to happen, actually. Seeing his surface antibody still negative. But interpreting Hep B serologies at any one point in time is always a challenge. It's better to have them separated in time. So in some degree, his non-compliance is awesome. because you got 6 month. Maybe if you can get him for labs, it'll be almost a 9-month difference between when you got your lab work and now. So,
Okay.
but he'll be a fun one to figure out. I personally wouldn't have hesitation in treating him with his negative DNA and his absence of cirrhosis. Definitely one that you don't want to ignore. I would follow his PCRs routinely.
With his, with his history of poor compliance with follow-up appointments, I think ideally what I would do if he had excellent compliance, I was going to treat him, I would, get labs, get his viral load and liver enzymes the day that we were going to start him on medicine, and then repeat those at 4 weeks when we did his viral load, and then probably repeat those close to the end of his treatment, and then see him again 12 weeks out. With his history of compliance, I expect to give him medicine and not see him again for 6 months, which of course is not ideal. Would that change your recommendations?
Yeah, it would. I would not feel confident in treating him without monitoring.
Okay.
So if you can get him engaged in care and definitely educated on the importance that he probably had, actually he does have both B, Hep, and Hep C, that we really need him to give us a solid 6 months of follow-up, 3 months on treatment and then 3 months of monitoring afterwards too. And probably, monthly lab work at least during that time period. So if he's serious about it, I would hate for this guy to disappear, get disenfranchised, and then come back cirrhotic in 10 years.
Right.
That's the downside
right.
of it. But at the same time, there are very few black box warnings on these medicines, and we wouldn't want to be cavalier with this patient either.
Right. So I think, he's somebody that we do have good rapport with. So I think I can just have this conversation about, I really need you to come back and see me frequently for the next 6 months. And if you're able to do that, then we can treat you at that point. That's worked well for me with other patients.
Kaylee and I have taken a bunch of patients through treatment like this, and we've not had any symptomatic reactivation in these healthy young guys, but he's certainly somebody who could. Following his liver enzymes and DNA would be important. So.
Awesome. Thank you all so much for the great comments and feedback. Dr. Bailey, were there any other questions you wanted to ask the group, or anything else with the case?
No, I think that's about it. I will throw in a quick other question about a patient that we just started working with. She had used recently used IV drugs for the first time in September, and so we're getting her in with therapy. She's been resistant to get into a Suboxone program, but she's been taking her husband's Suboxone, and her reason for not wanting to get in is because she takes Klonopin every day, and she would have to go off of the Klonopin. What are your thoughts about, she is actually somebody that is pretty darn stable most of the time with taking non-prescription Suboxone. And her husband is very stable in his sobriety. She just had this one incident. Assuming that she strings together 6 months worth of going to the therapist that I set her up with and not using any more drugs in that time other than the Suboxone that she's getting from her husband, what would your thoughts be on treating her?
I'll speak to her, Dr. Bailey. I mean, my personal, I would treat her. Remember the treatment restrictions are very much driven by the payer. And so, I'm not sure if her insurance would cover treatment, but, she's engaged in care. She's being upfront with you. It seems like she's been compliant so far. And even though she's not taking it as prescribed, I think that's, independent of her hepatitis C. So I wouldn't necessarily withhold treatment from her from a provider standpoint, but I don't know if you'll be able to get it approved through your insurance, if she's using illicit Suboxone or diverting it. Yeah. But I mean, you know, I've had some patients that have kind of utilized, I mean, I have patients that are active IDU, and I've still treated them. They're using a syringe exchange. They want their Hep C treated. I can't get them to stop using, but I've treated them through the that third party international gentleman that ships the Hep C treatment to them. They've been able to come up with the cost of the medication. I think it's like $800 now for a treatment course. So I mean, it's not ideal, but I mean, if we can't get insurance to pay for it in this country, that's kind of the alternate option I give them if that's their desire. And then I just follow their blood work.
Mm-hmm. Okay.
Jen, was there something as well?
Yeah, Dr. Bailey, why is it that she, I think you said this, but I forgot. Why is it she doesn't want to go into Suboxone treatment?
The programs that she has started in the past had taken her off of benzodiazepines.
Oh, right, Klonopin.
That's right. Yep, she's been resistant to that.
Yeah, it's interesting problem.
Yep.
Mm-hmm.
Awesome. Well, thank you all so much. I do want to leave some time for Dr. Gilfus's didactic as well for the last 15 minutes or so, but I wanted to thank both of you, Tammy and Dr. Bailey. We always appreciate the cases and they always facilitate such great discussion. So thank you both so much for your time. Dr. Gilfus, I'll just turn things right over to you for your didactic. I have it as backup as well, so if you need me to pull it up, I have it on my end, but I'll turn things to you now. Thank you.
Thanks, Mitra. And echo what you said. Joanna and Tammy, your cases are so appreciated, and they're always much more stimulating than these boring didactics. In fact, I'll give you guys an option. If we don't want to do a didactic, we can just talk about Twilight. If anybody's, you know, vote of hands or anything, it'd be more stimulating, I promise. I'm gonna share my screen, I think. All right. Everybody see it okay with a nod of heads? I can see people. Okay, cool. And so I went through half of this talk last time, actually just to kind of review. I'd gone through, you know, sort of a little bit about the viral genes, prevalence around in the US and internationally, how it's transmitted, how clinically it presents, and then went over the DREAD serologic studies and markers, and went through contingency of isolated core positivity. And now we are here at treatment, Hep B treatment. So I've got about 15 slides here, and I'll try to go fairly quickly. First things to know about hepatitis B treatment is, the first thing is, this is definitely a very different approach than you want with hepatitis C. With hepatitis B, you want to, you want to be patient, because for acute Hep B, it normally is going to go away on its own. And if anyone wants to call me out on that statement, feel free. You'll see if you're recollecting much from last time. You should say, wait a second, hepatitis B resolves on its own if acquired as an adult. Then, so remember, that's the big caveat. If you catch this as a child, it very likely goes on to be chronic. But as an adult, you've got a 95% chance of it going away. So in general, you want to hold off treatment unless you're have another good indication to do so, such as like fulminant, you know, liver failure or extrahepatic manifestation. Usually it's vasculitis or something like that that would push you to treat it. Otherwise, just sort of hold on and see what happens. Hopefully you're somebody who clears it on their own. So the who you treat depends largely on these four factors. So that the generic term is, you want to treat people who have evidence of virus replicating and hurting the liver. So how do we assess virus replicating and hurting the liver? Well, we have to assess viral replication in a couple of different ways. The E antigen has classically been how we look, but it's become recognized, if you all recall from the last talk, that there's a certain percentage of people who don't make the E antigen, called the pre-core mutants, patients with pre-core mutants that are E antigen negative, that are still having replication, and they don't produce the E antigen. So we can't rely just on the E antigen, although it's still very important. And if it's positive, it's bad. But if it's negative, make sure you still check the DNA and see if it's positive. Then the cutoffs for the DNA have a couple different set points, whether you're E antigen positive or E antigen negative. And it's completely counterintuitive. Basically, if you're E antigen positive, the viral load needs to be higher before you worry about treating. And if it's E antigen negative, the viral load should be you should treat even if it's fairly low. So that's the how do we assess viral replication via E antigen and the DNA. And then we look at the liver enzymes, so AST, ALT, and 2 times normal is the magic number. It doesn't do much good to treat non-cirrhotic patients whose liver enzymes are not more than 2 times normal. The antivirals don't really help much at providing long-term or durable viral control or improvement on liver damage. So the other thing you can do, I think everyone on this call is expert in non-invasive mechanisms of assessing liver histopathology. So we all know how to calculate APRI scores and FIB4s and checking the serum biomarkers and fibroscans. So that's the type of thing you want to do. And F2 is the magic number for where your concern increases to the point where you sometimes contemplate treatment. It's a very complicated algorithm. I'm going to kind of go through it quickly because I don't think it's worth memorizing. Biggest thing I want to push is for chronic Hep B, don't rush. You always want to sit back and make sure that it's not going to go away, number 1. Number 2 is you want to have an exquisitely reliable relationship with your patient before you launch onto hepatitis B treatment. Hepatitis B treatment is often lifelong, and it's probably the only infectious disease that I know of where I can actually hurt somebody more by treating them than not treating them. And it's not the treatment that hurts, but it's if they become non-compliant, you can induce a hepatitis B flare. So if they stop taking their medicines, they move, they just do whatever, you can actually harm the patient. So you really want to have a patient that you trust, that you've established therapeutic rapport with, and stuff like that. So you want to know, drag your feet, slow play it, and then go from there. And I will say that this is completely not true if the patient also has HIV. And the issue with HIV is not that it makes the Hep B that much worse, it's that you're going to be treating HIV usually promptly. There's no slow play for HIV treatment. A lot of times we suggest treating it, the day of diagnosis even. And the issue is that the antiretrovirals for HIV also treat Hep B for the most part. And so you want to be careful if you're treating a patient with HIV that you select a regimen that also successfully treats hepatitis B. And in fact, by far and away, the most common reason I treat people for hepatitis B is accidentally. I'm not even trying to. I'm just trying to treat their HIV. And by dumb luck, the antiretrovirals also take care of their Hep B. Endpoints of therapy are challenging. So for hepatitis C, we talk of SVR, the sustained virologic response. We have no similar cure endpoint for Hep B. It's never really over. Man, this is the second time I think in an ECHO program I quoted Katy Perry. That's a win. It's a big win. But it's never really over with Hep B. It just doesn't go away. How do you have confidence that it's kind of gone? You want to see somebody develop anti-E. So if they do have E antigen, you want to see them convert to anti-E. You want to see their surface antigen go away and their DNA become undetectable and their liver enzymes normalize. If you've done that and you can sort of keep them that way, I think that's on the next slide. Oops, a couple slides from now. That might be considered a successful endpoint of therapy, but even as such, when do you stop? The answer is we don't know, and I'm going to get to that. These are the treatments you can use. Believe it or not, some countries still use interferon, and it's not completely illogical. The only treatment up here that has a defined duration is interferon. So interferon can actually cure hepatitis, well, not cure, allow you to convert to anti-E and control your surface antigen in a finite time period. But it also is the most dangerous of the treatments up there because it can induce a flare. The other drugs up here all are potentially lifelong therapeutics when you start them. Lamivudine is the most data on it, and we still use it for some short-term prophylactic situations, such as if we're going to put somebody on hepatitis C treatment and we only need to sort of control them from Hep B reactivation for a short time period. If we need a drug that's really safe, incredibly well tolerated, and a long track record. But for hepatitis B treatment, so treatment of someone with a high viral load, it's a terrible choice. You will develop resistance. It's not even you might, it's you will develop resistance with time. Adofovir is another option we don't ever use these days because it's slow. It works sort of like tenofovir, but it's slower. The main two drugs we use are entecavir, which is pretty much our preferred therapeutic if you don't have HIV and are not pregnant. And then your other option is tenofovir, and it can be either derivative. Tenofovir alafenamide is, remember, tenofovir 2.0. It's the tenofovir that has been advertised as having less renal toxicity potentially, and then question mark, maybe less bone mineral density issues, but who knows on that one, but definitely safer on the kidney. So in general, tenofovir alafenamide, if insurance will cover it, tends to be preferred. So then again, this is the concept of treatment duration is we don't know. In general, when I'm counseling somebody of genuine hepatitis B treatment, I talk to them about lifelong therapy. I say, we'll probably do this lifelong. That's different than if you're just going to keep somebody on prophylaxis while you put them on Hep C treatment. And Joanne, I didn't talk to you about that as an option. I don't think you need to give that guy lamivudine, at least not right now, or anything like that. But if you're going to commit somebody to lifelong therapy, you really want a good therapeutic relationship with them. You can read on this concept of induction and consolidation therapy, where you sort of want to get somebody, the induction period is while you get somebody's viral load in a detector where their liver enzymes normalized, and then hopefully have them convert from E antigen positive to E antigen negative. That's considered the induction period. And then the consolidation period is about a year to 6 months after that. And then some people say that you could stop therapy at that point as long as your surface antigen's gone away, but that's really debated. And there's still a possibility it can come back. And so as you can see, again, this isn't to memorize. You can see there's just a lot of factors that you have to think about there. This is 2 pages worth of algorithms. And I promise you, Hep B is one of my favorite things to treat. And every time I start somebody on therapy or consider therapy for Hep B, I pull up one of these algorithms from up to date just to make sure I'm doing all the factors right. So again, you want to look at the patient if they have cirrhosis, no cirrhosis versus cirrhosis. You want to see what their E antigen is, if it's positive or negative. And there's different DNA cut points of concern, whether the E antigen is positive or negative. You remember, you really only want to offer therapy for non-cirrhotics who have elevated liver enzymes or have F2 fibrosis, and so on and so forth. So quite complicated. And it's a little bit more permissive if your patient has cirrhosis already, almost any DNA level, and you want to put them on lifelong therapy, etc. But I definitely advise that you use one of these flow sheets or algorithms if you're ever contemplating treating somebody. And remember those factors: the DNA level, the E antigen, the F2 assessment, assessment of fibrosis, and whether or not they have cirrhosis, and of course the 2 times elevation of liver enzymes. The most important thing about antiviral resistance is that it does not tend to happen with entecavir very often or tenofovir, but it happens with the other ones. Now, the big dread problem with hepatitis B is, unlike Hep C, it flares, and the flares can be dangerous. Remember that a flare can be a real trick because it can really look like acute Hep B for all intents and purposes. And even serologically, your body can start producing IgM core. And if we remember from the first half of this talk, I said that you define acute Hep B as the production of IgM core. Well, you can see that this is disproving that fact. And so if it's a patient that you don't know and they're presenting like an acute Hep B, but you know that they've had Hep B for about 10 years, it's actually probably a flare, not acute. The good news about a flare is if you once you pull through it, there's a chance that you might seroconvert into anti-E and have surface antigen clearance. So flares are not always terrible. They're just terrible while you're having it. In other words, if you live through it, it's a good thing, maybe. So when do you get flares? You can get it if you have HIV, and then we put you on antiretroviral therapy, and suddenly you have immune reconstitution, especially if you used a regimen that did not have tenofovir and lamivudine in it. Say you used an abacavir-based regimen or something like that, you can have active Hep B and then have immune reactivation and have trouble. You can get a super infection with one of the other A, C, D, or E viral hepatitis. You can get it during interferon therapy. You can get it spontaneously as your body decides that it wants to start fighting hepatitis B. Concerningly to me, and why I always want a good relationship with my patient, is you can get it during treatment discontinuation or emergence of resistance when you're treating a patient. And so you really have to counsel them not to stop their medicines. Don't let logistical errors happen, because unlike for HIV and Hep C, where there's just potentially less virologic control, the Hep B can flare and cause acute harm in those situations. You have to counsel your patients who have Hep B to be careful. If they get a bee sting or poison ivy or an asthma flare, to be cautious with steroid use. And of course, if they go have a worse diagnosis and need some form of agent immunotherapy, you can get a flare. And I think I talked about those two things already. So yeah, flares are potentially a good thing as long as it doesn't kill you. Good thing as in it will represent another almost acute hepatitis that gives you a 95% chance of clearing it. So it's kind of interesting. So, and remember, Hep B never really goes away. That's what that says here. Even in people who've developed surface antibody production, there's still a potential risk for reactivation. And if you ever have a patient who's going to undergo some form of immunosuppression that's substantial, there are risk categorizations, whether that chemotherapy is myeloablative, like going through a transplant, getting something like rituximab therapy. These are patients that have really, really high risk of reactivating their hepatitis B, even if their surface antibody is positive. So people who normal would say have good immunologic control, even those patients, if you really, really, really immunosuppress them with a transplant, really crushing immunologic therapy to their bone marrow or giving them rituximab, you can have reactivation. And so in these patients, there's things we can do, and we prophylax these patients a lot of times with medications for a finite time period. And that's sort of what this talks about, is we can start people on various therapeutics while we know they're going to be at risk from being on chemotherapy, or until their bone marrow reconstitutes, or until the rituximab gets out of their system in about a year. You can put them on prophylactic therapy and so on and so forth. And could do an entire different talk on triaging people according to preventative therapy. It's not worth it. Just know that there are articles that you can look up based upon, number one, your patient's serologic pattern. Are they E antigen positive, E antigen negative? Is their DNA positive or negative? And if their surface antigen and surface antibody are positive or negative, that's one factor, the serologic studies. Number two would be what chemotherapy or what immunosuppression are they going to undergo? So based upon those two, you can in general categorize somebody into high, moderate, or low risk and decide whether or not preventative chemotherapeutics are useful. And in general, anybody who's high or moderate risk, we go ahead and chemoprophylax, usually with lamivudine or something like that. Oops, sorry. And vaccination, Mithra, this is another topic that hepatitis B vaccination tends to be a mysterious topic and could potentially be a useful didactic in and of itself. Here are the indications for it, but there's always a lot of questions about non-responders and what to do about people who are core antibody positive but have no risk factors or potentially immunosuppressed. So there's a lot of cool factors that come into play about Hep B vaccination. But just know that right now it's built into universal recommendations for children, and a lot of reasons we should try to do catch up in adult patients, such as if you have a close contact with Hep B, Notice that multiple of these comments in here have to do with sexual transmission. So unlike hepatitis C, hepatitis B is very recognized as having sexual transmission. And of course, those who work in a blood-rich environment, healthcare field, get hepatitis B vaccinations. Those who go to dialysis and residential long-term care facilities, other chronic liver diseases, HIV, and of course, travel related, because we talked about there's a lot of areas of the world that have really high rates of hepatitis B. And then the last slide I have is an absolutely awesome slide that I wish I had something similar for hepatitis C, but we don't. For hepatitis B, we have amazing ways to prevent mother-to-child transmission. And in a single slide, those basically have to do with interventions to the baby after they're born and potential interventions to mom during the 3rd trimester. So most of the patients I see are the mom. I don't see children, but I'll see the mom during the 3rd trimester. And if their hepatitis B quantitative DNA goes sky high, or they have some other indication to treat their hep B, such as liver enzymes being 2 times normal or F2 fibrosis, etc., you can contemplate treating them and decreasing their viral load. The most common scenario I see is a mom with chronic hep B with low viral load in 3rd trimester pregnancy. And we don't tend to offer mom immunotherapy. I'm sorry, wrong word, antiretroviral therapy in that scenario. But what we always recommend, is that when the baby is born, they get passive immunization with immunoglobulin and immediately initiate on vaccination. And just that strategy alone is incredibly successful. We're talking to the point where it's not acceptable to transmit hepatitis B in the developed world to a baby. In the developing world, unfortunately, still happens a ton. As I mentioned, the endonicity in a vertical transmission is huge worldwide. But there's this amazing interventions we can do at the level of the neonate and to mom if the viral load is sky high or they have some other indication to treat their hep B. Questions or comments through that? And remember, it's not a topic that I want you to be comfortable with. It's not a topic you ever need to memorize, just trying to remember some of the factors at play when you contemplate therapy. And most importantly, that therapeutic relationship with your patient has to be concrete before you venture into anything to do with hep B.
Thank you so much, Dr. Gilfus. Jen, was there?
No, just thank you. It's always good to get an update or a refresher.
Oh, you're more than welcome, Jen. Appreciate you listening.
Absolutely. Thank you so much, Dr. Gilfus. I'm so happy you were able to finish part 2 of that talk. And I know Dr. Rexroad had to hop off here, but she chatted in saying she would love to hear a didactic on hepatitis B vaccination. So I'll definitely put that on the list for 2021. Any other comments or questions from anyone? I know we kind of are over the session hour, but I don't want to cut the conversation short. So feel free to unmute or anything. All right, well, thank you all so much. Thank you, Dr. Gilfus, for the didactic. Thank you, Tammy and Dr. Bailey for the cases. Just a couple housekeeping announcements. So our next session is actually going to be in 2021 on January 14th, and Kaylee's going to talk about initial HCV evaluation. So keep an eye out for that reminder. I just wanted to say that you all are so inspiring to me, and I'm extremely grateful for each and every one of you. I love my job because of you guys, so I just wanted you guys to know that. But I hope you all have a wonderful Christmas, a happy new year, and don't ever hesitate to reach out even during the holidays if you have a question or anything aside from ECHO. It doesn't have to be that, but if you ever need to reach out, I'm always here. So thank you all so much. We'll see you guys next time.
Love you too. You're the
Thank you. Love you, Mitra. You're the best.
Bye. Oh, thank you. Bye.